Good morning, I'm John Grigg and I have the great pleasure of introducing the 2022 Norman McAllister Gregg Lecture. The Norman McAllister Gregg Lecture was established in 1958 by the Council of the Ophthalmological Society of Australia in recognition of the outstanding contribution made to ophthalmology by Sir Norman Gregg. The lecture covers a clinical topic that has clinical relevance and may cover some facet of work that has not previously been published. It's a great pleasure this year to introduce Professor Ian McAllister, who is Professor of Ophthalmology at the University of Western Australia, a consultant ophthalmologist at the Lions Eye Institute, an emeritus consultant at the Royal Perth Hospital, and a member of the Board of Directors of the Lions Eye Institute. He specialises in the treatment and research of vitreoretinal disorders and treatments. Professor McAllister completed medical and ophthalmology postgraduate training in Western Australia before obtaining additional subspecialty training in vitreoretinal disorders in the United States. He gained a doctorate of medicine from the University of Western Australia on his return. He's had multiple NHMRC grants and has over 200 peer-reviewed publications. Ian McAllister is internationally recognised for his research in retinal vascular disorders. He has developed and maintained an exceptional research program over almost 20 years in this field. His work covers basic science, clinical ophthalmic research, and translation to clinical ophthalmic practice. It is my great pleasure now to ask Professor Ian McAllister to deliver the 2022 Sir Norman Gregg Lecture titled Retinal Vein Occlusion, Where Are We and Where Are We Going? Thank you, Ian.
I'd like to thank the College for the honour and the privilege of this presentation. Sir Norman McAllister Gregg is a true clinician scientist. He graduated in medicine with first-class honours. He was a very accomplished sportsman. He served in World War I and was awarded the Military Cross. On his return to Australia, he was appointed ophthalmic surgeon at the Royal Prince Alfred and the Royal Alexandria. In 1942, he noted an alarming increase in the number of children with congenital cataracts after outbreaks in army camps, which then spread to the local community. He published several papers on this association and made the link. However, unfortunately, this was not widely recognised or accepted outside of Australia until Professor Oliver Lancaster proved this association between rubella and the congenital syndromes, after which he was acknowledged as identifying this originally. He was awarded the James Cook Medal and knighted in 1953 and is importantly acknowledged for stimulating the development of the field of teratology. So what about retinal vein occlusion? This was first described in 1855 by this fellow, Richard Lebreek, in Germany. And this is one of his original hand-done drawings of retinal vein occlusion, and it's instantly recognisable even today as a central retinal vein occlusion. So we've known about RVO now for 167 years, so what visual results have we achieved? Well, unfortunately, until very recently, not much. It was 155 years later that the first treatments, which actually improved visual outcomes in retinal vein occlusion, eventuated. And these were the anti-VEGF therapies, which first emerged for RVO in 2010, and multiple trials have proved that. Also in 2010 was the first and only causal-based treatment for central retinal vein occlusion, the vein bypass. And since then, there's been refinements of both of these techniques, and we'll go through some of those today. So with CRVO, and we're going to concentrate mainly on this because this is the one that gives the most severe visual outcomes and the one that has the most problems in terms of longevity and burden of treatment that we face. So what are the problems that we still face in our treatment? Well, they're multiple, as you can see from that list there. You know, we don't know where the occlusion is, we don't know what it consists of, we don't know why it occurs at specific sites, we don't know the interplay of local and systemic factors in cause this. We don't know why the macula is so susceptible to edema and ischemic damage, why we get inner retinal neural loss even in the absence of capillary ischemia and damage in the macula. We don't know the intraretinal sequence in terms of cytokine upregulation. We've got very limited ability to give any prognostic advice. We don't know how to address the elevation in venous pressure. We can't address causal pathology. We don't know how to maximise visual recovery or prevent it, or to even identify patients who are at risk of developing this condition. So CRVO is a site-specific disease, and there's a natural constriction in the region of the lamina cribrosa where the vein and artery pass through this layer. And you can see, you can see this, this little constriction there in the posterior part of the lamina cribrosa, and here they're bound together with a common adventitial sheath. So if the artery is thickened, as occurs with hypertension and cardiovascular disease, the artery pushes in on the vein in this tight bound-in area, causing some constriction. And if this is an area of blood flow turbulence and hemodynamic stress, and this raises the tendency for thrombus formation. Now, early histopathologic studies identified in chronic vein occlusions as of the occlusion occurring here at the posterior edge of the lamina cribrosa. However, later studies by Hayray and by Beaumont and Kang in Australia indicated that this may be variable with some retrocribrosal, and in this position they have greater access to collateral development within the nerve, which may explain the difference in clinical presentations. Also, our group has looked at alterations in venous endothelium at these particular sites. And these are changes seen in the venous endothelium at sites predisposed to these sort of thrombotic or presumed thrombotic conditions. Now, venous endothelial cells are normally ellipsoid. In areas of hemodynamic stress, such as the focal narrowing that occurs in the retinal vein in the region of the lamina cribrosa, especially in those with hypertension and cardiovascular disease, the endothelial cells become more arterial-like, they become more spindle-shaped, and they develop a lot of contractile proteins, which normal endothelial cells in the veins contain very little of. And these only occur at two sites in the body. One is in the region of the lamina cribrosa, and one other is at certain arteriovenous crossings, both in the eye, nowhere else in the body. So this is also another study done by our group looking at endothelial cells, venous endothelial cells, and these do produce some contractile proteins. And venous endothelium is able to not only contract, but also is involved in signalling. It can contract in response to endothelin-1, which is an endogenous vasocontracting peptide, and this can be released in response to tissue ischemia. So in this isolated retinal vein study, in the diagram to your left, you can see two images of these veins. One is contracting in response to endothelin-1. And now this information is of value as these changes could increase the resistance of the drainage pathway, increase capillary pressure, and the contracted endothelial cells may increase vessel permeability through altering its barrier function. So the endothelial cells in the vein at these specific points may be major players in what we see in the ongoing progression of venous occlusion in these sort of conditions. So the causes of macular edema and retinal vein occlusion, there's basically two main causes. One is the hydrostatic pressure in the occluded vein, which can be up to 24 times that of normal venous pressure. And the other is the breakdown of the inner blood ocular barrier, and this is the role of VEGF, the downregulation of barrier proteins, and then secondary release of various inflammatory cytokines, and then recruitment of macrophages, etc. Now, our current treatments only address partly the second of those two causes, but not the first. So this is a study that we did prior to the advent of anti-VEGF, where we followed patients with central retinal vein occlusion over an 18-month period. And we divided their venous pressure at baseline into 3 categories. One was where it was low, where it was below arterial diastolic. The second was where it was above or just equal to arterial diastolic. And the high pressure was where it was equal or above arterial systolic. And you can see from this graph, which looks at entry and exit corrected visual acuity, those with high venous pressure basically ended up all blind by 3 months, whereas those with low venous pressure, they basically kept their starting visual acuity. Similarly, we looked at the progression of capillary non-perfusion according to venous pressure over an 18-month period. And again, those with low venous pressure developed very little capillary non-perfusion, whereas those with high venous pressure basically developed massive amounts of capillary non-perfusion very early on within the course of their disease. So venous pressure is a very good prognostic indicator of what the final visual outcomes will be in central retinal vein occlusion. We also looked at the progression of anterior segment neovascularization and neovascular glaucoma, and essentially those with high venous pressure, which is the light grey graph, or that light grey bar on that graph. These basically, 90% of these had developed anterior segment neovascularization by about 3 months. Whereas those with low venous pressure developed very little capillary anterior segment neovascularization. So given that we can accept that venous pressure is a significant, if yet unaddressed, component of the visual morbidity that we see in central retinal vein occlusion, what can we do about it? Well, we've developed a technique of anastomosing a retinal vein with an unobstructed choroidal vein. And these are the visual results from our original randomised controlled multi-centre trial, which we conducted prior to the advent of anti-VEGF, where we used a high-density power laser to create this anastomotic connection. Now, this is the change in visual acuity compared to control eyes, and you can see over an 18-month period that there is a gradual improvement in vision over this period. This is in contraindication to the fairly rapid rise that you saw from the first study of ranibizumab for central retinal vein occlusion, where there's a rapid improvement in visual acuity, and this is maintained over the next 12 months, although there was some deterioration in the visual acuity over the subsequent second year in the Horizon study. And this illustrates why this happens. This is a series of photographs from one of our patients treated with this anastomosis, and you can see that there's a fairly rapid reduction in the hemorrhagic retinopathy and the clinical features of central retinal vein occlusion. But what is slow to resolve is the macular edema and consequently the visual acuity. So this takes over a year to resolve if left just to the anastomosis alone. So this leads to the next logical point, was why not combine these two therapies? So you've got on one hand the anastomosis dealing with the elevated venous pressure component of the edema in CRVO, and on the other hand the anti-VEGF addressing the upregulated VEGF cytokine as a consequence of the occlusion. And here again, this is one from our study that we subsequently did, where it shows a rapid resolution in the hemorrhagic retinopathy and also a rapid resolution of the macular edema, and consequently a good improvement in visual acuity, which occurred rapidly. So we then conducted a randomised prospective study comparing a combination trial of the anastomosis and an anti-VEGF, in this case it was ranibizumab, versus monotherapy with ranibizumab. And this was all done according to the CRUISE trial protocol. So all patients received either anastomosis or a sham at baseline, and then all of them commenced ranibizumab at month 1, and this went for 6 months, and then there was a follow-up observational PRN treatment period, which went out to 4 years. So all of the data assessments for both groups were taken at month 1 when both treatments commenced, or both arms commenced the ranibizumab. So we had a success rate for anastomosis creation of 82.5% in the combination group. And you can see in this group of photographs, this is the anastomosis sites, and you can see typically this is the amount of hemorrhage that we will see after creating this anastomosis, where we have to puncture not only Brooks membrane but also the side wall of the retinal vein. And here, this is again a before and after at 12 months, and you can see in that bottom image with those arrows, those very large choroidal veins, that the retinal venous blood is now exiting the obstructed retinal venous circulation. It's not going out through the central retinal vein any longer. It's plugged directly into large choroidal veins and exiting the eye through the peripheral vortex veins. This is another interesting group of patients that we collected through these studies, and these were all patients that at presentation had not only the central retinal vein occlusion, but they also had a quite prominent optociliary shunt vessel, indicating that they may have had something occur in the past, or it was a very slowly developing one. But the interesting thing is that after they all developed an anastomosis in the bottom series of photographs there, if you look carefully at the optic nerve, you can see that those optociliary shunt vessels have all disappeared, indicating that really the hemodynamic effectiveness of a naturally occurring shunt vessel on the disc is fairly limited. This is the visual acuity changes taken over the 4 years of follow-up. Now, all data measurements were taken from the 1 month time point when both groups commenced ranibizumab, and I've divided the combination group into 2 categories, one that developed an anastomosis, which was 82.5% of them, and the one which failed to develop an anastomosis, just to demonstrate the visual results that can be achieved when venous outflow obstruction is addressed in addition to the VEGF upregulation. Now, at the 4-year time point, which for these studies is quite a long time, the control group alone had an improvement of 11.3 letters, which is pretty consistent with the results, 1 and 2 years of those major randomized clinical trials. The group with the functioning anastomosis, by contrast, had an improvement of 17.4 letters. And the difference between the functioning anastomosis group, also combined with ranibizumab as needed, versus the control or monotherapy group was 14 letters. So a very significant improvement. The group with the functioning anastomosis had no difference compared to the control group. This is the injection requirements required over these study time points. And during the observational PRN treatment phase, the injection requirements for the group with the functioning anastomosis were consistently much lower than the control group. And at the 4-year time point, in the 4th year, the control group required 1.84 injections mean, and the group with the functioning anastomosis only required 0.25 of an injection, what was their mean number of injections. The non-functioning group, no difference to control. Now, this is a diagrammatic representation of the 3-dimensional capillary structure of the macula, and this demonstrates how relieving venous back pressure in RVO may improve outcomes. Now, the macula has got 3 layers. It's got both a serial and parallel arrangement of the capillaries. So the deep capillary plexus is particularly susceptible to venous back pressure, as it has no direct arterial input, with the arterioles passing through the first 2 layers first, but it does have some direct venous drainage to a retinal vein. So with a low arterial inflow pressure and a high venous back pressure, as will exist in a retinal vein occlusion, this makes this layer particularly at risk of blood flow stagnation and ischemia in an RVO, which may explain our better visual results in the anastomosis trial. We did look at venous pressure in those that developed an anastomosis, and for this we divided into two groups, basically below and above arterial diastolic. The top graph is the baseline, with the blue being the control and the orange being the combination group. That's the anastomosis and the ranibizumab. And unsurprisingly, at baseline, virtually all of the patients in this group had high venous pressure. However, at 2 years, there was a 82.5% reduction in the odds of having a high venous pressure in those with the functioning anastomosis. So a very big difference in the final outcomes in terms of venous pressure. We've also done a considerable amount of work in laser developments to improve the success rate of anastomosis, and this is very dependent on having sufficient power density to create the required anatomical defects in both Brooks membrane and the sidewall of the vein. Standard lasers don't have enough power. With our current laser, which was specifically developed by Alex for this procedure, our success rate of anastomosis has risen to 88%. Another problem with retinal vein occlusions is this inner retinal damage that occurs. And this is a patient at presentation treated with anti-VEGF. A year later, their last injection was 4 months ago. You can see from the angiogram there that their capillary vasculature is intact. However, they're suffering a reduced visual acuity and have a significant loss of the inner retinal neural layers compared to the unaffected eye. And we've looked at some of the changes that occur in the eye in an acute model of branch retinal vein occlusion. For this, we've used the pig. The advantages of that is that it's got a very similar retinal architecture. We can create a photothrombotic vein occlusion. This occurs at a specific point in time, so we've then got an exact timeline to measure changes within the retina, and we can measure alterations in retinal cytokines and proteins following this intraretinally rather than measuring vitreous and aqueous levels, which most studies have done. These don't take into account potential binding to other proteins or barrier effects of the internal limiting membrane. So this is just a macroscopic view showing the thrombus within that vein, and I would emphasise that this is an acute model, and the results, whilst instructive, don't necessarily apply to what happens in a human. So this is using this pig model, and we've looked at inner retinal neurodegeneration in the immediate aftermath of an acute branch retinal vein occlusion. Now, tunnel detects apoptotic or dying cells with fragmented nuclei, and you can see from the graph on your left that this rises dramatically in the first 2 days, which is due to ischemic necrosis, before falling to lower levels. By contrast, cells with pycnotic nuclei rise by 2 days and remain elevated for at least 3 weeks. Now, these are an early feature of apoptosis not detected by tunnel, and cell death is potentially reversible. So that there is a time window for any potential neuroprotective therapy if we had such a therapy available. Now, this is tunnel cells in a BRVO, and also BRVOs treated with an anti-VEGF. In this case, we used Avastin, or a steroid, which we used triamcinolone. Now, tunnel positive counts for the untreated branch veins, so much the same pattern with the rise at 2 days and then falling to very low levels. However, those treated with Avastin, which is the bar graph, which is black, shows a very significant rise at all time points compared to the steroid or the untreated BRVO. So VEGF in itself has significant neuroprotective features in its own right, and we may be seeing here the potential unmasking that protective effect by the introduction of a profound VEGF antibody. And this may cause potentially further loss of inner neural elements. And this is looking at the pyknotic cell counts, which in cells are potentially salvageable. And again, we can see these cell counts, whilst they're both higher for the anti-VEGF, the black line, and triamcinolone, the steroid, which is the coarse hatched line, than for the untreated BRVO. This indicates that anti-VEGF in the very acute phases may unmask this neuroprotective effect of the VEGF, which is upregulated. We've also looked at some of the intraretinal cytokine upregulation, and virtually all of these studies, as previously mentioned, have looked at changes in aqueous or vitreous, which is not a true reflection of what's happening in the retina. Now, the relevant ones are, firstly, this one, which is GFAP. Now, the earliest non-specific Mueller cell response to injury or early gliosis is this upregulation of GFAP, and we can see a significant upregulation at all time points. We also looked at other Mueller cell markers. Mueller cells play a very vital role in maintaining retinal osmohomeostasis and are richly endowed with proteins such as KIR4.1 and acroporin 4. Now, dysregulation of iron and water homeostasis occurs early, and this is shown by the downregulation of the KIR4.1. Now, this is a potassium channel, and it leads to an inability to extrude intracellular potassium, which again leads to swelling and intracellular edema in the Mueller cell. Now, the aquaporin 4 is upregulated, but this may be upregulated to compensate for that. Interestingly, VEGF is not upregulated early. There's a mild rise at 2 days, which may reflect some immediate necrosis, and then levels drop over the next 3 weeks, perhaps due to loss of cells producing this cytokine. We have shown that it does rise thereafter and remains fairly high. So in the initial acute phase, there's not much in the way of VEGF upregulation. Interleukin-8 is an inflammatory cytokine, and this shows a profound rise at all time points, and this has been implicated in the downregulation of endothelial gap junction proteins. GFAP, as we mentioned, is one of the earliest and most sensitive rises, and this is a Mueller cell effect. And this graph shows a significant rise in GFAP over these time points, and also the response to both the steroid and the anti-VEGF. And you can see that the ones with the black line, which is the anti-VEGF, remain very high, where there is somewhat of a protective effect with a steroid. And GFAP remains upregulated for many weeks. This is at 11 weeks after BRVO. The one on your left is showing strong immunoreactivity with the VEGF. You can see very nicely it's stained along those Mueller cells, whereas the one on the right is the one treated with triamcinolone. This is 11 weeks after, so there's still a downregulation. This is Oclusion, which is one of the barrier proteins in endothelial cells, and again this is at 11 weeks. The figure on the left is showing an untreated BRVO showing reduced staining, and the one on the right shows significant enhanced immunoreactivity. And this is maybe the effect of the steroid is probably related to both its downregulation of VEGF and interleukin-8, both of which downregulate Oclusion. We also looked at whether thrombolytics would be a potential treatment for retinal vein occlusion. And for this, we used tenecteplase, which has some significant benefits. It lasts longer, it's more resistant to inactivation, and it has much less arginine than TPA. And the other big advantage is that it penetrates the retina, whereas TPA does not penetrate the retina from an intravitreal injection. And this is one of our, again, pig models. The A is the normal pig eye, B is a branch retinal vein occlusion and ejected with, B is just a normal eye injected with TPA, no vein occlusion, and you can see the TPA staining within the whole level of the retina. And C is one where we've created a branch retinal vein occlusion. You can see quite a lot of uptake within the vein itself, indicating that this does penetrate well. And this is a histological study, a branch retinal vein occlusion at 3 weeks. And then the second one is again 3 weeks, but this one had an injection of TPA at week 1. So, encouraged by this, we did go on to a small trial of acute branch retinal vein occlusions in humans, and this is at presentation on your left. This is 1 week later after the injection of the TNK, and you can see that it looks really quite encouraging. It's improved quite a bit, but by 1 month, we're back to square one. So our small study would show that whilst there's some immediate resolution, this rapidly reoccurs. And in reality, the presumed thrombus, which occurs at these sites of susceptibility, is the penultimate event in a whole series of pathological and hemorrhagic events which occur at points of anatomical susceptibility, and analysing it with a thrombus, thrombolytic will only result in its rapid reoccurrence. So, treatment duration, there's a big burden in treating these patients. So natural history studies it takes sometimes 3 years for edema to resolve. There's a very high dropout rate in patients in both prospective and real-world studies. In the recent SCORE study, which went for 5 years, 45% only completed the 5th year, and of these, 66% were still requiring treatment. Adrian Hunt, if you went to his talk earlier, put together a very nice 3-year follow-up of patients with vein occlusion and found that 50% were still requiring anti-VEGF at 3 years. So, what are our treatment approaches to CRVO? So basically, at some stage, we're going to have to realise that pharmacological therapy will not be the penultimate treatment for CRVO. So where are we really with CRVO? So pharmacological therapy is unlikely to be the final solution. Current treatment burdens are unsustainable. Central venous pressure remains a large and unaddressed component, and it's unlikely that we're ever going to be possible to revascularise an occluded central retinal vein. Those who try, it's really a very simplistic approach, and it's not going to work. Natural collaterals are slow to development and hemodynamically insufficient. The cause and propensity for certain individuals to develop CRVO remains obscure. It's possible to create alternative pathways, but perhaps more work needs to be done on the sustainability and success rates. The intraretinal cytokine cascade in response to venous obstruction is complex and certainly not limited solely to VEGF. Neurodegeneration occurs early, and I think we're going to need a more nuanced approach in what agents we use and at what particular point in time to treat this and to limit further progression of this in our management. Thank you. And thank you once again for the honour of presenting this talk.
Congratulations, Ian. That's a wonderful Sir Norman Gregg lecture. It really extends the work that Sir Norman Gregg started, identifying the important role of a clinician scientist. You develop clinical observations, therapies, and then investigator-led trials to highlight and investigate the work. So congratulations on a wonderful Sir Norman Gregg lecture. As part of the award, you have a certificate and a medal.
I've got your medal. Thanks.